But now I'd like to introduce Dr. Nasi, and Dr. Nasi actually started at Texas Scottish Rite in 2009. Really, she came from Stanford where she did her undergrad, and she basically did her entire medical career at UT Southwestern. So usually when someone's really, really good, an institution doesn't let them go. So that was clear with Dr. Nasi as medical school residency, as well as her fellowship here at Texas Scottish Rite. And although she takes excellent care in all of our kids with any kind of pediatric arthritis. She also has developed a specialty, or what I would call her an expert in, is she's part of a study group that looks at childhood vasculitis, and she has also written about childhood lupus as well as Wegener's granulomatosis. I hope I said that correctly.
You did.
It's a little bit of a mouthful for a sports surgeon. So Dr. Nasi is going to talk to us about how do I know if my patient has arthritis or related condition.
Okay.
Thanks, Dr. Nasi.
Yeah. So this is supposed to be interactive, so if you have any questions, please stop and ask. So first of all, I know what people think about pediatric rheumatologists, right? So a lot of mysterious girls get together, burn some herbs, read some tea leaves, and then they come up with a diagnosis that nobody has ever heard of and prescribe some medications that are entirely too expensive, right? That's what we do, yes? All right, not quite like that. So basically it's a team of people coming together and sorting through symptoms and presenting features and the certain lab values that can help us determine what pattern is present. So at the end of the day, rheumatologist is simply a patternologist, right? Rheumatology just comes down to simple and straightforward pattern recognition. So the idea is you want to identify a specific set of symptoms, and then you recognize, or if you don't recognize, search for the specific diagnosis that fits the symptoms and findings. Then you want to determine whether or not you think the immune system is involved. If you think the immune system is involved, you want to determine which part of the immune system is dysregulated, because then you can determine appropriate targeted therapy, right? Gone are the days when rheumatologists just used to bang everything with steroids. We should not do that any longer, and we definitely try not to. However, the key with rheumatology is always to stop and reconsider anytime the pattern is different. Okay. So today specifically we're going to talk about how juvenile arthritis specifically is diagnosed, what are some of the subtypes, some overall treatment strategies. I know one of the big questions for me to cover was treatment. I think that's a little bit difficult to cover in a brief lecture, but I will talk about some treatment strategies and some rheumatic and non-rheumatic conditions which can mimic juvenile arthritis. Okay. So undoubtedly, whenever I meet someone and say, you're a pediatric rheumatologist, so what do you do? Because kids don't get arthritis, right? That's what people will always tell you. Unfortunately, that is not true. And arthritis is still the #1 cause of chronic disability, acquired disability in childhood. So in the day and age where we have excellent targeted biologic therapy, this is telling you that a lot of kids are getting missed, okay? And they're getting delayed diagnosis, delayed treatment for a number of reasons, but certainly this is a huge problem. So it actually constitutes about 300,000 children in the United States and 4,000 children in the state of Texas alone. And when you consider that, unfortunately, pediatric rheumatologists still number less than 300 in all of North America, so Canada, United States, and Mexico, we're undoubtedly outnumbered by this condition. Okay, so what is arthritis? So everything comes down to symmetry, right? So if you're not used to doing a musculoskeletal examination, you can just think about symmetry. So at the end of the day, you have swelling, right? So you can see this is the normal side. You have nice, clear, bony demarcations, whereas this side, all of that is completely lost. Okay. What about pain? Technically, yes, for the diagnosis of arthritis, pain with range of motion is one of the criteria. However, for juvenile arthritis and chronic arthritis, there was a lovely study that demonstrated if pain is the chief complaint, the likelihood that the diagnosis of arthritis is actually decreased, okay? So that's a key point. Our kids with juvenile arthritis, usually pain is not one of their huge chief complaints. All right, what about limited range of motion? Absolutely. You can imagine if your knee is this swollen, you can't move it very well. The other finding on this picture that you'll notice is this is the normal thigh, right? This is what it should look like. On this side, you can tell this is a chronic arthritis because they have some quad atrophy here because of disuse. All right. What about warmth and erythema? The reason I put these small and at the bottom is, again, for chronic juvenile arthritis, we don't typically see those. That's much more consistent with an acute process. So if you have a really red, hot, swollen joint, you have to be worried about something else. Okay, So back to the chief complaint, right? Joint pain versus arthritis. So again, there's a huge difference. You have to have true swelling in the joint for arthritis to be present. What about acute versus chronic? So by definition, we treat chronic conditions, right? So they have to have persistent swelling in at least one joint or more for at least 6 weeks or longer. So the swelling cannot come and go. It cannot hop around to different areas. It has to be persistent in at least one place. What about subacute presentation? Yes, so that's how our kids present. They can't tell you it started on Thursday, it started on Friday. They say maybe it started 2 to 3 months ago. No one exactly remembers. If it's acute, obviously that's much more consistent with an acute process, not one of my processes. So definitely our kids get stiff after they're still, so particularly in the mornings after long car rides at the end of the school day. Okay. What makes them better? So definitely warmth tends to make them better in anti-inflammatories. However, I would caution you, remember that anti-inflammatories are also analgesic medications, so they will make everything undoubtedly better, yes? The other thing too is our kids are usually doing things normally. If you have a child who stopped going to school, who stopped doing their normal activities, that really is much more consistent with a primary pain amplification or a kind of a pediatric version of fibromyalgia, not juvenile arthritis. So what review of systems are the most important to the pediatric rheumatologist? First of all, constitutional symptoms. If they have any fevers, weight loss, anything like that, that really constitutes something that's very concerning and needs more of an acute evaluation. What about ocular symptoms? So I'm going to talk about it a little bit more in depth in a minute, but certainly kids with primary arthritis are at increased risk for inflammation in the eye, so we care about that very deeply. Why is GI on there? So inflammatory bowel disease can very, very commonly present with arthritis as a chief complaint. So certainly we diagnose several inflammatory bowel disease every year. Then finally, cutaneous manifestations. So connective tissue diseases of a feather flock together, right? So we have a lot of cutaneous manifestations of our primary disease processes. Okay, so back to the original point because this is really important, right? So arthritis is defined by joint effusion, okay? Or two of the following, but I would say most typically they do have swelling. So truly, the history is important, but the physical exam is absolutely critical. Okay, back to this point, is it red or not? So you can see the list of the things that are red, for the most part, are very concerning things. So if it is very inflamed, you have to be concerned that there's an acute process that needs urgent evaluation, right? If it's not, then that's much more common with a primary juvenile arthritis. Okay. So, just to prove home the point, even once you have the diagnosis of arthritis, it still does not a diagnosis make. So the most common cause of arthritis is actually reactive arthritis in childhood, with post-strep being the most common form of reactive arthritis, and actually and certainly the one that we most want to recognize because actually that's the one that we treat. So then primary inflammatory conditions such as JIA, which is primarily what we treat, so infections, systemic connective tissue diseases such as lupus and dermatomyositis, primary oncologic conditions, primary immunodeficiencies can also present with arthritis as a chief complaint. And obviously trauma is a very common cause of swelling in pediatrics. Okay, so by definition, you have to be a child. So we arbitrarily define that as less than 16. You have to have arthritis for at least 6 weeks or longer in any one joint and a diagnosis of exclusion. So it cannot be present for some other reason. All right. So these are some of the subtypes, and we're going to talk about these with some cases in a moment, but just kind of as a brief overview. So systemic arthritis is a form associated with fevers and rash. Oligoarthritis just means 4 or fewer. Polyarthritis just means more than 4. Psoriatic arthritis is a very specific subtype of arthritis with either personal history of psoriasis or family history. Enthesitis-related arthritis is really what goes on to become ankylosing spondylitis later on in childhood. And undifferentiated is just simply a grab bag category for all the different kinds that don't fit into the other categories. So we're going to actually focus on the main categories that are the most common today. Okay. So back to this. So making the diagnosis, so the history is important, but the physical exam is critical. One thing that you will note, did I mention one single lab test here in the diagnosis of arthritis? Absolutely not. So just to kind of hammer home that point, so labs can help us rule out other diagnoses, and they can help us determine if you have systemic inflammation and if you have other systems that are involved, but they do not make the diagnosis of arthritis. Okay. So which brings us to my next point. You keep on checking that lab, but I do not think it means what you think it means. So we always get this question, right? What labs do you want me to draw? And today I'm going to try and convince you is don't, unless you're specifically worried about infection or cancer, okay? So now why is that? So please wait. So first of all, if the child does have a connective tissue disease, I'm going to have to draw their labs anyway, right? Because I'm going to start them on medications which are going to require monitoring. So what happens is the kid's already been poked once, and then I'm going to have to poke them again, and the parent gets mad at me because I'm the one that has to poke them again. So again, please remember, you don't need to check labs for me, okay? All right. What about the rheumatoid factor? We all love rheumatoid arthritis, right? Well, that's great, but the rheumatoid factor is in fact negative in 95% of kids with with juvenile arthritis. That's actually part of the reason why we changed the name from primary juvenile rheumatoid arthritis to juvenile idiopathic arthritis. And actually, if you remember what the rheumatoid factor is, all it is a nonspecific antibody. So it gets released every time your immune system is turned on for whatever reason. So the most common cause of a positive rheumatoid factor in childhood is actually a viral infection. Okay, what about the ANA? Same thing. So ANA is very useful in ruling out lupus, but it does not anything diagnose, right? So in fact, it's actually present in probably about 20% of normal, healthy children. And so truly, the most common cause is post-infectious or really any other condition. And so again, not useful for diagnosis. What about the HLA-B27? Okay, this is very useful to risk stratify for sacroiliitis. However, remember, ankylosing spondylitis is actually a radiographic imaging diagnosis. It does not matter if they're HLA-B27 positive, HLA-B27 negative. What matters is what their MRI shows. And so truly it's present in about 10% of the normal healthy Caucasian population. So right, so that's about like 3 people in this room, right? And I'm guessing that 3 people in this room do not have ankylosing spondylitis, yes? So just please remember that. All right, what about CBC? CBCs are very useful for chronic inflammation. However, most of our kids, even with severe arthritis, actually have normal blood counts, and so you really can't predict if they have terrible arthritis based on their CBC. Same thing with the SED rate, all right? The most common cause of an increased SED rate is it's winter in Texas, right? All right, so the take-home point, if you're worried that the kid has arthritis, absolutely be worried and refer to us, but you do not need to draw one single lab value in order to get into our clinic. Okay. So now actually, since we talked about all the painful stuff, now I get to talk about the cases. All right, so if you want to remember one kid from today, please remember this one because this is our most common diagnosis every day of the week. Okay, and actually they're one of my favorites. So this is a 3-year-old white girl who's been noted to have a limp in the morning. As the day goes on, her limp gets better until the next morning when it comes back. Her preschool teacher says to her mom that she's been having problems when she's been sitting in circle time, keeping her legs crossed. All right, she's had no fevers or rash. This child is otherwise well. Her parents say, oh, yeah, she fell off the slide a week before the limp started, and she is otherwise well appearing and no complaints of pain, but has left knee swelling. Okay, so just to go back to our thought of what arthritis looks like, right? So this is the normal healthy leg, right? So that you can see the nice, clear, bony demarcations. And she can actually hyperextend this side, right? So most kids are a little bit extra flexible, so that's normal. This side is huge and swollen. You can't see any clear, bony demarcations. And not only can she not hyperextend it, she holds it flexed in what we call a flexion contracture. So this is what chronic arthritis looks like. Okay, so this is oligoarthritis. This is our most common diagnosis every day of the week. So its most common onset is between ages 1 and 4, and we say 4 joints or fewer, but it's usually 1 or 2 joints, and it's usually the large joints, usually knee or ankle. So most of these are little girls, and they're usually little white girls. So the genes that are most common in this condition are most common in Northern Europe, and they actually decrease from there, so we have a lot of freckly, blue-eyed kids running around our clinic. Okay. So these have the easiest to treat joints and the hardest to treat eyes, and I'm going to show you some pictures of that. And so unfortunately, in fact, about 1/3 of these kids will develop a chronic uveitis. Okay, so presentation, just like we talked about, you have to have swelling in at least a single joint for 6 weeks. So what about the history of trauma? Well, what's the most common age this presents at? 2. What are they doing chronically? Falling all the time, right? That's what 2-year-olds do. So it's really just a red herring. The parents remember it because they're trying to attribute the swelling to something else. Okay. So what are the cautions? So just like we talked about before, if it seems like it's acutely inflamed, that should be very concerning to you. So if it's red or very painful, if they have isolated hip involvement, that is very uncommon, and so we have to think about that a little bit more carefully. Any systemic manifestations, right? So these kids do not have fever, weight loss, anything like that. These kids are well. If there's any refusal to bear weight, usually these kids are a little stiff and achy in the mornings and they're running around the rest of the day. If they have isolated single joint involvement in a small joint, that's uncommon, but it can still be in the right clinic. It's just probably in a different diagnostic category. Okay, So the uveitis. So this is very important, right? So this is really what is the most problematic thing for these kids. Unfortunately, it's usually asymptomatic, and you can imagine about 2/3 of these kids, when you're 2, you can't tell people things are starting to get blurry and I can't see as well, right? So they don't have an acute red, painful eye. They just start to go blind before anyone knows it. So in fact, in the majority of times, it's usually bilateral. So early on, they have inflammatory changes, but late on, they get scar tissue. So about 10% can actually precede the onset of the arthritis. About half is at presentation. The rest usually follow the next 5 to 7 years. However, that risk never goes away. So these kids truly have to have eye screens for the rest of their lives. Okay, so these are the pictures. So I think this shows up, right? So you see these little white dots. So these are inflammatory cells that have actually precipitated in the anterior portion of the eye. So, and you think about the pupil, it should be round and smooth, right? Well, you see these outpouchings here along the pupil. These are what are called synechia or scar tissue. So actually what is done to try and avoid this is they actually get prescribed cycloplegic medication that forcefully dilates the eye. So if you see a quote unquote blown pupil in the rheumatology clinic, don't call 911, they're probably just on one of these medications. Okay, this is band keratopathy. So this is true like calcinosis or scar tissue in the anterior portion of the eye. You cannot see through that. Okay, so what is the treatment for this? So absolutely, old school anti-inflammatories are still first line. If that is insufficient, then we go on to corticosteroid injections. And if they're treatment resistant or high risk, we actually use the same medications that we would for a polyarthritis. This is actually new from when I was a fellow. So these kids used to get synovectomies and serial casting and all sorts of arcane treatments. But we actually don't do that anymore. We actually use some of the more newer biologics when they have problems. Okay, so why do we inject early as opposed to leave these kids on anti-inflammatories forever? There was a lovely study that was done that compared 2 different centers, so Washington and North Carolina, where Washington group injected early and the North Carolina group did not. So unfortunately for the North Carolina group, those kids developed leg length discrepancies as well as flexion contractures and thigh circumferences discrepancies. So again, chronic changes that the Washington group did not. So now everybody injects early. Okay. So what about this? Has anyone heard the phrase, you will grow out of childhood arthritis? Yes, no one's saying yes, so I'm guessing that that's no then. So you already know then, hopefully. So this is a lovely study. People used to say that. This is a lovely study that was done in France that looked at kids 6 years from the diagnosis of oligoarthritis. And so the question was how were they doing, right? So unfortunately, about half of them developed a polyarticular course. Fully 1/3 of them developed bony erosions, 1/3 of them developed uveitis, and only 1/3 of them were in remission. Okay, so this is a chronic condition like diabetes or high blood pressure. This is not something people will typically grow out of. Okay, so this brings us to the next case. So this is Carrie. So Carrie is a 9-year-old, again, a blue-eyed blonde, who's been having problems getting in trouble in PE because she can't do push-ups for the last month, all right? So her teacher also tells her mom that she's been having problems with handwriting, especially first thing in the morning. And the mom owns up, I've been having to get her up really early in the morning because she gets ready really slow lately. Okay, so this is a picture of Carrie. So off the bat, you can tell that this is an arthritis patient who has been missed. So Carrie has a very small, underdeveloped chin. She has narrow shoulders, and then she has these chronic contractures in her bilateral fingers. Okay, so this is an up close of Carrie's face. So again, symmetry, yes? So your chin should be almost even with your nose. And you can tell that Carrie's chin isn't anywhere near her nose because she has had chronic arthritis in her TMJ, and her TMJ has failed to develop normally. All right, so this is up close of Carrie's fingers. So you can see she's already developing what we call boutonniere deformity. So flexion contracture with hyperextension in her fifth. Then she has swelling really pretty much diffusely everywhere in her hand. Okay. So this is polyarticular arthritis. So by definition, they have 5 or more joints. They most frequently have a symmetric type arthritis. They have age distribution includes 1 to 4 as well as kind of a later onset school age years. Again, like most things in rheumatology, it's much more common in females. So again, just to point home and drive home the point, most of the handy-dandy rheumatic labs are negative here, right? So if you draw these labs thinking that you're going to evaluate a child for arthritis, you're going to be wrong the majority of the time. So now a subset of these kids can develop uveitis, but less frequently than the oligos. Okay, so what kind of problems do these kids get? So growth disturbances, just like we showed you with Carrie. So they get an underdeveloped TMJ. They can conversely get overgrowth or leg length discrepancies in the side that's active with their legs. And then their fingers conversely actually can get premature closure, and so they get these little claw-like hands. So overall, they do get impairment of normal bony mass, and this is the number one predictor of this is chronic steroid use. So absolutely, people who really do polyarthritis now feel that there has no role for chronic steroid use in any kind of primary arthritis. Okay. So what is the treatment? So methotrexate, old but effective, is still absolutely first-line therapy. And then there's a whole host of biologic agents. And I know that we want to talk about therapy a little bit, but again, I think that's a little bit outside the scope of this talk. But just sufficient to say that there's a lot of different chemicals that we can specifically target now depending upon the underlying cause of the arthritis. Definitely, we do still do targeted joint injections. But again, please remember, if you want to remember one thing about treatment, is there is a very limited role for steroids in these children. Okay, which brings us to someone completely different. So compare and contrast this case with the first two. So this is Christopher. So Christopher is a 10-year-old Hispanic male, and he's been missing a lot of school due to multiple viral infections. Okay. For the past 2 months, he's had fever to 105, so not subtle fever, right? Usually in the morning and early evening. He's had a rash that comes and goes with the fever and problems with handwriting. He has also had a weight loss of 10 pounds. All right, so time out. Do you see all the check marks? This is like a concerning case. This is different than the others. This is someone who needs to be evaluated immediately, right? Okay. So his parents say, I've taken him everywhere. So he's seen oncology, infectious disease, GI. He's had all these studies, had a bone marrow biopsy, endoscopy, all of which were really unremarkable. So he presents to your office with the following rash and problems making a fist. Okay, so this is the classic rash. And I'm not going to lie, it doesn't always look this perfect, but I show it to you just to remember it. So this is what we call a macular papular eruption that's usually salmon pink, most common on the trunk and in the axilla, okay? And again, this will come and go with the fever. So if you see them at a time when they don't have fever, you may miss this rash. All right, so this is systemic arthritis, or what used to be known as Still's disease. So it can truly present at any age, any ethnicity, and either gender. So it can truly present in anyone, including adults. Okay, so what do they typically look like? So the fever is absolutely the hallmark of this condition, right? So they have that high grade, what we call quotidian or double quotidian fever pattern, usually first thing in the morning, early evening, okay? Again, not subtle, not 101, not 100, they're 104, 105, hot, hot, hot. Okay, they can get lymphadenopathy, they can get pericarditis, hepatosplenomegaly, and here's another picture of the rash. You can tell this is a little bit subtler, and you can also see sometimes it's pruritic. This guy's been kind of scratching at it. What about the arthritis? So the arthritis can be very variable in these children, okay? So they can present with multiple joints, or they can present with zero. And you guessed it, these kids are sick. These kids actually can die fairly quickly. So we do not wait for them to develop arthritis before we treat these children. All right, so what are some of the hallmark labs? So lots of inflammation, so high white count, high platelet count, anemia. Hyperferritinemia is absolutely one of the hallmark findings that we see with these kids. And again, handy-dandy rheumatic rule-out labs are completely unremarkable for these children. All right, so how do we treat it? So let me read some rheumatology tea leaves for you. So this is what we call a gene expression study. And so yellow is kind of normal expression, red is upregulation, and blue is downregulation. So you can see these yellow stripes. These are the healthy controls, okay? All the red are the systemic arthritis patients. And I will save you the trouble, but what stands out here is this IL-1 signature. So I don't know if you guys remember what IL-1 does, but I'm going to actually remind you. So IL-1 is a pro-inflammatory cytokine, right? So it's released by peripheral blood mononuclear cells, goes to the brain, causes fever. Then it goes to endothelial cells and releases IL-6, which is another pro-inflammatory cytokine that goes to the liver, causes your acute phase reactants to raise, goes to the bone marrow, increases your white count, increases your platelet count. So all of this is just primary inflammation. So that's absolutely what's going on in these children. You'll see that TNF is actually not anywhere on this. So Enbrel and things like that is what we tried to treat these kids with, methotrexate. None of it worked. So here at this institution where we did this study, we tried a medication called anakinra, which interestingly enough blocks IL-1, and it worked like a perfect. And so it was a lovely, it was absolutely life-changing for these kids who used to have no effective treatment. He used to end up in the hospital all the time when I was a fellow for steroid pulsing, and truly this has been life-changing. So when anakinra does not work, there actually is another medication called Actemra, which blocks IL-6, which if you'll remember is downstream from IL-1, so that makes sense as well. And we do use methotrexate as an adjuvant agent, but really again, these kids need aggressive treatment because these children can die. Okay, which brings us to Monica. So Monica is a 14-year-old Hispanic female who's had joint pain and progressive decreased mobility. She too has been having problems with handwriting, but she has also been developing facial rash, fatigue, mouth sores, finger changing colors when she gets cold, low-grade constant fevers, so totally different than Christopher's fevers, and she also has lost 10 pounds over the last couple of months. So Monica's vital signs give her away as if the rest of the story didn't, because she is hypertensive at the same time as being febrile. 14-year-old girls are very, very rarely hypertensive, right? And if I needed to make it any easier for you, this is her picture. So this is a classic malar rash. You can see, I get a lot of kids that are referred to me for malar rash who have nothing more than easy flushing. This is what a malar rash really looks like. It is very clear, it is very crisp, it is very distinct. You almost feel like you can touch the margins. So here she has classic sparing of her nasolabial folds. And again, she also has mucocutaneous involvement as well. All right, so this is lupus. So again, much more common in adolescent females. African and American Hispanic girls have much more severe and earlier disease onset than their Caucasian counterparts. Okay, I always tell people, even medical students, I don't want you to memorize the lupus classification criteria. I just kind of like you to group them in your mind so that you can keep in context that lupus can cause any kind of problem, right? All right, so it can cause mucocutaneous problems. So absolutely, they can get rashes, they get photosensitivity, they can get mucocutaneous ulcers. All right, they get major organ manifestations. This is what kills them, right? So their renal disease or CNS disease is absolutely what causes them the most amount of problems. Hematologic disorder, absolutely. Arthritis, they can get pericarditis, pleuritis. And the hallmark, these patients make tons and tons of antibodies. Okay. So in childhood, lupus is usually not subtle, right? So these children, we're usually meeting them in the hospital because they're very ill. So they have multi-system disease, they have a number of diverse clinical features, and a significant amount of end organ dysfunction. So these children are sick, sick, sick. We do not do well with this condition, right? So this is not a disease that we're going to get in constant remission. They're going to flare the rest of their lives. Okay, so just to kind of reiterate this, so adult lupus, what's the natural history of lupus, right? Death, okay? So 5-year survival, less than 50%. However, think about adults. They only have half that are impacted with nephritis. That number in pediatrics is 90%. So even though we don't have great data in pediatrics because we don't leave them untreated, right? We think that the pediatrics, we have more severe phenotype, and so we actually have less time to end organ damage. And so these children oftentimes end up on dialysis. All right. What's the treatment? So here, up to this point, I've been talking about beautiful targeted biologic therapy. Do I have beautiful targeted biologic therapy for lupus? Nope, right? So unfortunately, steroids are still main line therapy, and they come with a host of problems that everyone is well aware of, right? So weight gain, high blood pressure, diabetes, long-term effects on growth and bone development. Also chemotherapy, right? So these kids are in and out of the hospital getting true chemotherapy protocols, so these children are sick. Then other immunosuppressive agents if they have milder disease. All right, which brings us to the next case. So compare and contrast that one with this one. So this is Tyrese. Tyrese is a 14-year-old African-American girl who you know has lupus, and she's got bad lupus. She's got class 4 lupus nephritis. So she has the sudden onset of pain and swelling in her left knee, and she's unable to ambulate. So totally different than Monica's untreated arthritis everywhere, yes? So, and of note, Tyrese got chemo 2 weeks ago, all right? Her review systems is otherwise negative. Her exam, normal, except for the big knee, and her labs absolutely give her away. All right, so lupus patients get cytopenias, right? So they get a low white count. So her usual white count's around 3.8, but not just that, I gave her chemo 2 weeks ago, right? So the Cytoxan nadir, when it takes effect, is about 10 to 14 days after you get it. So her white count should be 2. All right, but it's not, it's 12.4. So her SED rate, which is usually in the 50s, is now 109, and her CRP, which should be normal, is 24. So this child has an infection of some sort. All right, so her knee aspiration was inflamed, and she was sent home from our emergency room with no antibiotics and diagnosed with a lupus flare. All right. So at home, she was nice enough to go ahead and develop some fever to 102. At 24 hours, her culture grew out gonococcus, and she was called back for admission. And she got treated with antibiotics and ultimately did well, but this could have gone much worse, right? So infection is absolutely the leading cause of mortality in lupus in the first several years. Later on in life, they will die of heart attacks and strokes, just like the rest of us, but early on, infection kills them, right? So remember, chemotherapy does not necessarily take effect right away. So in fact, for cyclophosphamide, you don't see the effect until about 10 to 14 days out. So whenever a child's on a chemotherapy protocol, it's always very important, when was your last chemo? How long ago was that? Also, kids on chronic steroids do not necessarily mount fevers in response to infection. So a lot of our kids who are on chronic steroids can't do that. Also, what does lupus arthritis look like? It's polyarticular and it's in kids who are untreated. You do not get a single knee in a kid who's on chemo, right? So that's something that is completely atypical for what we would see. Also, so a really key point here is CRP does not elevate with lupus activity for reasons that are poorly understood. But if you have a lupus patient whose CRP is elevated, they have an infection. Also, the other thing, too, is lupus patients are immunosuppressed even if they're not on immunosuppressive medications. So I don't know if you remember the complement cascade from medical school, but basically complements are proteins that get consumed in lupus activity, and they're very important for addressing certain types of infections like gonococcus and pneumococcus. And so our patients really have problems with specific types of infection. All right. Okay, so this is my last case before we turn to the last topic. So this is Lizzie. So for those of you who don't know the story, so Lizzie at the time was a 7-year-old half Persian princess, half British thornbush, who had acute onset of leg stiffness in her right hip. So she had pain. So at the time, they were out of town at the Pediatric Orthopedic for a fundraiser for the Pediatric Orthopedic Hospital, where her mother works at part of the time as a pediatric rheumatologist. And the dad, who's also usually a very smart physician, looked at the mom and said, "What?" And she said, "I don't know. She's just been talking to my kids," and she picked up the lingo. But she gave her some ibuprofen because that's what she does. But the next day, Lizzie had pain with limp, okay? Lizzie never, ever complains of any kind of pain because she would never, ever do that. So the mom appropriately freaked out, drove right back to Dallas, where she was taken to the emergency room, where she had an x-ray that was normal. Patted on the head, told to go home. But that was not the end of the story, because in the middle of the night, Lizzie screamed and woke up crying, saying that she couldn't use the bathroom because she couldn't walk. So the mom went in, found that her right hip was flexed and externally rotated, and the mom said, "Oh, shoot." And they went back to the emergency room. However, her labs only showed mild inflammation. She had an ultrasound that showed a moderate effusion, but because the kid was willing to walk on it, was once again sent back home. However, the mom, being the type A, obsessive-compulsive, nervous personality that she is, pleaded with her friend to be seen the next day, where indeed her CRP had doubled. So she was taken to the OR that morning, and she got IV and PO antibiotics, and then she was completely well, because yes, this is a pediatrician's shameless excuse to show a picture of her adorable daughter. So my daughter had a septic hip when she was 7, and you can tell she's totally fine now. But this does allow us to illustrate the point that we were talking about earlier, right? So this is acute onset, so acute pain, right? So I joke that pain that wakes the kid and the mom, but not the dad, because it takes a lot more than that to wake the dad up, right, in the middle of the night. Refusal to bear weight, isolated hip, and she got better immediately. Does anything that I do get better immediately? No, right? It takes a long time. So this is completely different. Okay, so I think that we have time to cover the last topic. And this was asked for me to cover. And so what happens when the rheumatology patient ends up in my clinic? So everybody panic. Don't panic. Okay. For most patients, there's no specific precautions. What if they're on chronic steroids? Well, actually, a lot of research has shown us recently we probably don't need to do as much stress dose steroid dosing as we used to, right? So if they're in the ICU and they're hypotensive, yes, they need stress dose steroids. Otherwise, probably not. Okay, what if they're autoinflammatory spectrum, like systemic arthritis, like our friend Christopher? Look, anytime they're stressed, they can die. So they actually get their biologics increased whenever they get stressed, including surgery. So please, if there's some kid like that, we need to be involved, because they're probably going to need some help in order to get through any kind of stressor. What if they're on anticoagulation? Well, that's complicated, right? Because if they're on aspirin because of one blood test that they had 3 years ago, we can probably hold it. Whereas if they're a lupus patient that's had 4 clots, they're probably going to need a heparin bridge, and so that's a little bit more complicated. What about anti-inflammatories? Sure, hold them, we don't care. Methotrexate, most biologics, no undue concern, which brings up the specific perioperative recommendations. Okay, so what are these recommendations? Are they lovely evidence-based recommendations based on 10.4 bazillion patient years? No, absolutely not, right? They're consensus-based guidelines. Okay, and they were supposed to be focused for specific rheumatic disease in adulthood undergoing specific procedures. However, in general, we have extrapolated them for a number of different diagnoses and a number of different procedures. But very important in the statement is the ultimate determination regarding their application to be made by the physician in light of each patient's individual circumstances. So I really do feel strongly that we have to consider each kid and specifically what their poor outcomes might be when we make these recommendations. Okay, so what are they? So there's this painful chart that does not need to be that painful because they can be summarized in 3 sentences, right? So DMARDs continue. So methotrexate, Plaquenil, blah, 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 does not matter, does not need to be stopped, they can just continue it. What about biologics? Okay, well, so this is where you get this complicated chart, but again, it does not need to be that complicated because you ask the kid this, hey, how often do you take your Enbrel? And the kid says once a week, and you say, okay, so then you can wait 1 week until they've had their Enbrel, and then they can have their surgery after that. Then the basic recommendations are 2 weeks provided after the surgery, provided that there are no complications. Now, at the very bottom of this list, you'll see lupus. So in the very bottom, you see not severe lupus. You want to ask me if I've ever seen not severe lupus? Nope. So assume for all of our kids who have lupus that they have severe lupus and that their medication should not be stopped because they might end up in the ICU. Okay. So what is the evidence behind these recommendations? Well, DMARDs is pretty clear, right? So DMARDs, they've done some lovely studies that show if their DMARDs are held, the people do worse. So they have increased risk of both infection and flare of their disease. So DMARDs are clear, we should continue. What about biologics? Okay. Biologics are a mixed bag, even just for the TNFs alone. However, the vast majority of studies show that there's really no benefit to holding for more prolonged intervals with respect to infection, wound healing, et cetera, et cetera, et cetera. And actually, even in the guidelines, they admit, why did they make these recommendations? Did they make them for any specific concerns? No. They made them specifically just for the general concern about the increased risk of infection. So ask yourself this, what is the most common biologic that our kids are on? Enbrel, right? What is the infection that our kids with Enbrel get? TB. Is TB a post-op complication that I'm aware of? Not that I'm aware of, right? So again, the specific infections that these kids are at risk for, I don't think are hugely problematic in this specific subpopulation. And then furthermore, so severe connective tissue disease, autoinflammatory lupus, dermatomyositis. If you think the kid might die if you hold their medicines, let's not hold their medicines, right? Okay. So that is it. So lupus and arthritis are clinical diagnosis. The history is important, but the physical exam is critical. So if there's any evidence of systemic inflammation, so fevers, weight loss, anything like that, they really deserve a prompt evaluation. And definitely our kids, sometimes we need to be aware that they're at increased risk for infection and other things because of the medications they're on. And that is it. Any questions?
I appreciate the talking thing, but one thing I'm particularly curious in some of the kids I've seen with arthritis is what activity restrictions do you have with a kid that has lupus and perhaps maybe an athlete, and the parents are wondering what they need to do to adjust that? And then the second question is, is there a role for PT for some of these kids that have lupus, or not lupus, but of any form of juvenile arthritis? And what's kind of your recommendation for the kids?
So let me take question number 1 first. What are activity recommendations and limitations? So you asked specifically about lupus. So, if they're on Coumadin, they can't play contact sports because they might get a head bleed, right? If they have C-spine arthritis, again, they shouldn't play contact sports because I'm worried about their neck. Otherwise, really, our basic overall theme is if it doesn't hurt, you can do whatever you want for the most part. So as long as they don't have specific findings in one specific area that would complicate that. The second part of the question, is there a role for therapy? Again, it depends on what the specific problem is. And so certainly for localized scleroderma, absolutely there's no question, right? It can help prevent flexion contractures. It can help with range of motion. For other things, it's a little bit less clear. So for arthritis, for the most part, I like to think that we're doing a better job. I mean, sometimes when our kids are a little bit non-compliant with their medications, they don't do quite so well. But for the most part, we don't have as many flexion contractures and things like that as we did when I was a fellow, right? So we should theoretically have less of a role, but still sometimes there is a focal role for specific joints. Did I answer the question? Any other questions?
We have a patient in clinic we're going to refer to you, and we're going to put them on NSAIDs. Do you have a preference of ibuprofen versus naproxen?
Okay, so do you want the doctor answer or the mommy answer?
How about both?
Okay, the doctor answer is it absolutely makes no difference. The mommy answer is, can you give your kid who's 6 a medication 4 times a day? I can't, right? So I do naproxen because it's twice a day. Any other questions?
And when you were going over some of the diagnostic, cues into juvenile arthritis at the very beginning of your talk, which I thought was an excellent review, I noticed that, swelling of the joints is really the primary diagnostic tool that we have, but your desire for those of us who don't treat arthritis regularly, but perhaps screen them, and then we're the ones who wave the red flag and say, "Hey, you need to see a rheumatologist." I noticed that you say over there joint effusion or.
Yeah.
So oftentimes I'll wonder if I should refer someone there.
So,
but limited range of motion and tenderness on tenderness or pain on motion would be.
So I have a cheat here for you, right? Because the other criteria that's not on here, that's not incorporated formally, that is used every day of the week, imaging, right? So Yassine or Joseph can use their fancy ultrasound wand and tell me if it's inflamed or not. And so, if there's a question, then ultrasound, MRI is absolutely diagnostic. And I do it all the time, right? So a lot of our kids who've had chronic synovitis, who have this really thickened synovium, I can't tell if it's swollen or not. And so we get imaging all the time, just routine screening to see, is this actively inflamed, or is this just old disease that's done that I'm not going to be able to impact with medications?
Great. No, I think that's really helpful. So if you're suspicious of an arthritis, as opposed to blood work, the preference is ultrasound.
And it's cheaper, right? So that's the ironic thing. Like all those rheumatologic labs, that's like $2,000 worth of blood work, right? $2,000 worth of tests that don't help me. Whereas ultrasound, I don't even know how much that is, but not very expensive, right? That will actually give me the diagnosis.
And we're spoiled here because we have experienced radiologists that do pediatrics that are used to ruling out inflamed joints, but perhaps some in the community may or may not have resources to that. So I guess my question would then be, is if you don't have our expert group here and you're in the community, is your recommendation MRI with contrast of the joint in question, or do you find that community ultrasounds can still do an adequate job of establishing synovitis in some of these difficult to see?
So ask the follow-up question, do I trust the outside radiologist to read those MRIs even? No, right? So we get stuff all the time that is read as marrow edema that we'll have them overread here, and they're like, no, that's just red marrow conversion in a growing kid. That's completely normal. And so I would say if there's any index of suspicion and you have a concern, I would just refer them. So ironically, this is going to sound terrible. I do this at Children's, right? So I'll see a patient at Children's, and I'll refer them to myself at Scottish Rite just so I can get imaging. And so, I'm shameless about it. And so I would suggest that, you do the same. If you have a kid that you are suspicious has arthritis and you're not sure, I would just refer them, let us examine him, and let us do the imaging in-house is what my preference would be. Sorry, there's silence. Why? Is that the wrong answer? Was I supposed to give a different answer?
No, I just, I oftentimes try to find reasons not to refer things to you because we've got a lot of hypervigilant parents that their knees are always swollen and they are always have joint pain and they always have limited range of motion.
So you're not from the outside, right?
So
you can get imaging here, right? And so that's what I do. So I don't know. So I skip down to Yassine and ask him what,
Gotcha.
itis present, itis not present, and he tells me yes or no. Yes.
How long does it take to get people in to see you?
Well, I think my wait is 8 months at Children's, and I think it's 2 months here. That being said, you can always call one of us directly and let us know that someone needs to be seen, and we can get them in acutely.
One of your earlier slides, what is a DMARD?
Oh, I'm sorry, disease-modifying agent. I'm sorry. So that's methotrexate, Plaquenil, kind of the older medications that have been around for a while.
This question's coming from someone very non-clinical, so forgive me if this is a known fact, but is there any hereditary component to this?
So actually, this is a great question. So there have been a number of different what we call HLA associations or specific kind of immunogenetic markers, but none that have really elucidated the causality of arthritis. And I would say usually when we diagnose arthritis, they're the first person in their family to have it. So clearly there's genetics involved, but definitely that's not the whole story. But that's a fantastic question.
I've got more.
Yeah, cute.
I was wondering if you could just comment very briefly, because I know you guys commonly treat enthesitis, and if you could maybe just let us know a little bit about what you believe is a form of, because it's not all enthesitis that you treat, but there is a specific form that you can add value to.
All right, so what he's referring to is so there's a specific subtype of arthritis that I referred to, but I didn't talk about because it was kind of a little bit outside the scope. That's called enthesitis-related arthritis. And so this is what goes on to become ankylosing spondylitis in adulthood, right? So the problem here is a lot of times, so I talked about how swelling has to be present. These kids can actually be a little bit more subtle than this, right? So sometimes they can start with someone diagnoses them with Sever's disease or Osgood-Schlatter's, and they go on to develop this, that, and the other. And then years later, they develop their arthritis, and lo and behold, it turns out that they have a primary underlying inflammatory condition. So what I would say is if they're a kid who has one single local area, my index of suspicion is lower. If they've had sort of multiple different areas, my index of suspicion is higher. And here family history comes into key. So I'm not going to lie, I probably have some kids who are 12-year-old Hispanic boys who've had nothing more than Osgood-Schlatter's or Sever's or whatever, but they tell me, oh yeah, some uncle had some kind of back thing in Mexico and nobody knows what that was about. And so I follow them once a year and just kind of do a joint check and just, sort of check in with them to see how they're doing. Because, ankylosing spondylitis is a terrible disease to miss because we have a treatment for it now, right? We can prevent the terrible repercussions of it. And so I feel like for me to do a joint check once a year and make sure that a kid's not developing into that is pretty easy to do. Oh, Enbrel, so TNF inhibitors. There's newer biologics too that I didn't refer to, but still first-line treatment is TNF inhibitors.
So if I see a kid in clinic with especially a male with stiffness in the low back that that I've ruled out kind of musculoskeletal type of stuff, and then I'll be honest, I do get a HLA-B27 on them. I'll just do a ESRC or PMA.
So which one, so I don't know the answer to this,
Okay.
but my guess is that the MRI is more cost effective than the B27.
I don't know. So I'll get the blood work, and then my other question is, if I don't see anything exciting, then I will do imaging.
So ask yourself this question. Can you have ankylosing spondylitis with a negative B27?
Yes, from what you're just saying, yeah.
And can you have no ankylosing spondylitis with a positive B27?
Yes.
Yes. So I would say if you have a high index of suspicion for sacroiliitis, especially if it's a teenage Hispanic boy, I would not pass go. Because if you send them to me, I'm going to MRI their SI joints.
Okay.
And not check the B27, unless it's positive. If their MRI is positive, then I would go ahead and say oh, do you have a B27 positive also? Because that has repercussions for their kids in the future. Any other questions?
Any last minute questions?
Was this helpful, hopefully?
It was.
Okay.